Hello, thanks for your time today. This presentation is about the Quality Indicator Measures training. My name is Mallory Duncan, and I'm the Program Director of the Rehab Center. And thanks for your time. The objectives of today's talk are, one, for you to understand the upcoming regulatory changes that are going into effect on October 1st, 2019. The second objective is for you to understand why it matters. So I want you to understand how your QIM scoring directly affects our patients and why it will soon be your most critical piece of documentation. The third goal is to develop knowledge of QIM coding. So it's a whole different scoring system, and by the end, hopefully you'll be an expert. We're going to review some specific sections of the inpatient rehab facility patient assessment instrument. So that's some data that we collect for our payer sources. And then our fifth objective is to be able to pass your competency test. So super excited. FIMs are going away. It's the day that we've all been dreaming of, and they will no longer be something that's part of what we have to do on acute rehab as of October 1st, 2019. So that's updated as of the week of June 26th. We have about 100 days left, and I'm certainly counting down. Why QIM? Why not just leave well enough alone? This is part of the Impact Act of 2014, which is a congressional act. And what the government wants to do is better track patient outcomes across all the post-acute levels of care. So when I'm talking about post-acute levels of care, that's basically anywhere that someone can get therapy. So it might be an LTAC or skilled nursing facility, home health even, and then us, the acute rehabs. And the objective is to enable interoperability so we can access longitudinal information. So right now, the LTAC, SNFs, home health, us, everybody's comparing bananas to apples to oranges to pears because everybody's just in their own silo doing their own thing. But the purpose of the Impact Act is to make sure that we can follow a patient across the places that they might be. So if a patient starts in the acute care and goes to an LTAC, we want to be able to see how far that they get there, and then if they come to acute rehab from there, we want to see how they continue to make improvements, and so on and so forth. So longitudinal information. We are also discussing transparency. So all of this data is going to be publicly reported. So even right now, you can go to a website called irfcompare.com and you can put in your address and see all of your options for acute rehab. So this QIM data is our functional outcomes data. So someone that lives in, say, O'Fallon or Collinsville, that might be right in between us and our competitor, St. Elizabeth's, can type in to this website and see, do we do a better job at Anderson of getting our patients home, of getting them independent, or to St. Elizabeth's? And then they, as a consumer, have a choice. Also, transparency for our payer sources. So if Humana or Molina wants to see that same information and sees, hey, Anderson Hospital does a great job with stroke patients. We'd rather our patients go there than St. Elizabeth's. That could be really impactful. Either way, good or bad for us. So that's what I mean by transparency. There's a couple major themes for this change. So it's not just a minor change. It's a really big deal. First and foremost, there's completely different scoring scales. The good thing about QIM is that it eliminates a lot of quirky nuances. So for a FIM, there's all kinds of stuff that you have to remember about assisted devices and hearing aids and walkers and memory medications. We don't have to worry about a lot of that. So in a lot of ways, it's a much simpler. Assistive devices and time, they no longer impact ratings. So that's not going to score a patient down just because they use a walker. So I really like that about this system. Just to understand kind of a very basic why we care, when someone comes to acute rehab, we get a predetermined payment to determine how long a patient can stay here. So a patient comes to our unit and they're grouped into one of more than 90 different groups. And the things that matter when we're considering what group to put them in, and this is super simplified, but it gives you a general idea, is their diagnosis, sometimes their age, certain comorbidities, like if they need dialysis, and then most importantly to you guys is the QIM, so their functional abilities. And as I said, this determines resource allotment. So based on the information we give the payer sources, they, quote, establish the length of stay for optimal outcome. End quote. So basically they tell us, can the patient stay 5 days? Can the patient stay 10 days? Or can the patient stay 15 days? So it's really, really, really important to our patients because I really believe in the right level of care at the right time. 3 days, 3 extra days in acute rehab make all the difference in the world to these patients. 3 days could absolutely be the difference between going to a nursing home for a month, 2 months, for forever, or going home. And that's what we're all about, is getting these people home where they belong. So this is really, really important, guys. We also measure patient and program outcomes with our functional data. So we've always talked about FIM gain in the past, but now we're talking about QIM gain, and it's the functional information that tells the patient's story. So the patient came in needing substantial help with everything, and they left just needing setup help. So it's telling the patient's story. We also look at our goal attainment, and that is the goals we set for ourselves, as well as the goals that the payer sources set for us, which are two kind of different beasts. But when we're talking about the goals that we set ourselves, we can pull these reports and see how we do. Let's say most of our patients have a goal to be independent on stairs, but we see from our trends that most patients don't achieve that. We can think clinically about what we can do to change the actual clinical services we provide to make that happen. So maybe we need to start the stairs earlier, or we need to actually use the staircase instead of the stairs in the gym. So it has clinical implications for making sure we're performing at the height of our game. And then lastly, we can compare ourselves to other programs. So hopefully this is not new to you. This is called our Program Evaluation Model Score. So you'll hear PEM score. And this is our facilities report card. And they care about a couple things. You get graded based on where your patients go when they leave. So of course our goal is to get as many people as we can home. And you can see on this slide that we actually get a little extra credit. They gave us 101% of the available points because we're sending more patients than they even expect to go home, which is amazing. And if you look below that at the discharge to acute care, we have even more extra credit because we're really good at handling what we need to handle here on the unit. But if you go up kind of where the blue is, this is our functional based things. And if you go over to the fourth column, you would see that we've only gotten credit for 64% of the available points. So if there's area to improve, it's always our functional stuff. Also wanted to mention though that our PEM score is really, really solid, and we've seen really, really great improvements. So our FIM scores are coming along, but hopefully we don't have to worry about that too much longer. So just to give you a little bit of historical background on the QIMs, in 2016, the government said, hey, start collecting these measures. And so we did. But up until now, they were completely irrelevant. So we didn't care. I didn't really monitor them. You're not getting emails all the time about your QIM scores, your QIM scores. So we haven't really done much with them. You guys as therapists are familiar with the domains, so walking 50 feet with 2 turns, walking 10 feet, walking 150 feet. That's all familiar to you because that's been around since 2016. But what's different to you guys is that we never changed in the EMR the actual coding system. So we've always used it with FIM language. And so the language of the quality indicators is what's going to be different to you guys. Also want to mention that nursing's never reported on any of the FIM, so they don't know any of the domains and they don't know the language. So as therapists, we're at a little bit of an advantage, which is great news. There are a couple new concepts for assessment. So just like we did with the FIMs, we still have 3 calendar days at admission and at discharge. So we care about the first 3 days, and we care about the last 3 days, and that is unchanged. However, we are no longer taking the lowest score. So I'm going to give you an example that I see all the time. Not really. I'm going to give you an exaggerated example. So let's say a patient transfers 20 times within the first 3 days, and 19 times they were completely independent. If one time, even a single time, you had a second person stand by them just in case, considering burden of care as you're supposed to with the FIM, that score would be a total. For the IRF-PI purposes, we would use that total because you use the lowest score, but that is going away. So this is going to be hugely impactful in that our patients aren't going to be able to stay as long. So it's really important that we're using the quality indicators appropriately so we don't get shorted at any time. So that we're already going to be expected to do more in less time, but we really want to give ourselves a fair shot. So it's important for accuracy. And then the second big thing I wanted to mention is that we no longer are allowed to carve out the 24 hours that we want at discharge. So that's what it's been in the past. So we care about the last 3 days, which essentially translates to the day before they go home and the day before that. So that's when you see our time to shine posters up on the wall. And that's supposed to be a visual cue to you as a therapist. Hey, let them really show you what they can do. Let them be as independent as possible. Now, it certainly happens that somebody will come in and do something totally expected, scoring. Like maybe it was just a straight scoring error, or also maybe the patient normally is totally independent, but they just had an oopsie and they lost their balance, and so we had to mark them as a min for whatever, but we know they can do better than that. Because we have the flexibility to just choose whatever 24-hour period we want, like say from 8:10 a.m. to 8:10 a.m. the next day, that's fine. We can score around that score, but that is going away. So now everything that happens in those last 3 days is going to be really important. This is something that's going to be a little bit new, but I want to make sure you have a really good understanding of what they're asking for. So when we're talking about admission, when we're collecting these quality indicators on admission, we're talking about collecting a patient's baseline status. So we want to know before we've done them any good, before we taught them energy conservation, before they've gained strength from the exercises we've given them. We want to know how they did before that. So the data that we're giving them on admission should reflect the patient's usual baseline status before interventions. So I'll say that again. Data should reflect the patient's usual baseline status before interventions. Okay, so we know that everything we do as therapists is an intervention. The second that an evaluating therapist goes into the room, they're starting to intervene. What do you do as a physical therapist? You bring your walker with you and you're like, hey, you can't walk around by yourself. That's not safe. I'm going to show you how to use this walker. That is an intervention. That's not the goal of this, giving them this baseline data is not to say how they did after you gave them an intervention. So just like we've been talking about for a year and a half about the FIMS and making sure we capture the appropriate burden of care based on their prior level of function, that same concept applies to the admission assessment quality indicators, okay? So basically, if the patient didn't use a walker before, in most cases, it would be totally appropriate to try them to walk 10 feet without a walker. Most of them aren't going to be able to do it, but just wanted to make sure that you realize that as soon as you start intervening, we're changing here what we're collecting, and what they're asking for is usual baseline status before interventions. So I also want to add that nursing's role to capturing baseline data is going to be so important. So especially that day of admission when therapy doesn't even see them at all. So we want to know right when they get to the unit, as close to admission as possible, how are they doing before we start doing this patient some good. So now we're going to dive in. One of the things that we're looking at that's kind of goofy because it's very different than the other quality indicators, but I wanted to make sure that you know that it is a quality indicator, is their prior level of functioning. So this is captured by the evaluating OT, PT, or speech therapist, and just like we always have, you can gather this information by talking to the patient, talking to the family, or reviewing the medical record, looking at the screen, so on and so forth. So there's a coding system here. Pretty familiar. You don't use the numbers as written already in your existing evals, but you either write that the patient was independent, needed some help, dependent, or we don't know, or it's not applicable. Just wanted to point out, because this is nothing new, so you guys are already familiar with this, that when we're talking about self-care, we're only talking about bathing, dressing, toileting, or eating. Anything that's kind of beyond that is probably captured in cognition, but they're definitely not talking about IADLs. They don't care about making a meal or cleaning their house or stuff like that. So if they have like a chore worker just for those things, doesn't matter. You would still put them a 3 independent for bathing, dressing, toileting, or eating. Then we look at indoor mobility, which is ambulating, being able to walk from room to room. Doesn't really specify a height or a distance, rather. For stairs, could be internal or external stairs. And then the functional cognition part is shopping, taking medicines, so some of that more IADL type tasks. I'm not going to read that one to you. Another one of the quality indicators, weirdly, is previous device use. So here are the specific options for the IRF-PI: a wheelchair, a motorized wheelchair, a mechanical lift, a walker, a prosthetic or orthotic, or none of the above. So you can see that cane wouldn't influence that. That's totally fine. I write that they used a cane, and you totally should write that they used a cane, but the IRF-PI doesn't specifically care. So when you're making sure that your data is complete, so if they used a walker and a wheelchair, make sure that you have both listed in your eval, basically. About the mechanical lift, that could be a Hoyer, which is, I think, is where our minds immediately go, but it could also be a stair lift or a bathtub lift. So if they mention anything that requires a motor, then you would include mechanical lift. And then walker also includes literally any type of walker that you could imagine, including our rolling and our standards, but also rollators, knee walkers, basically any walker. All right. So if you weren't paying attention, zone back in with me because we're going to go over the scoring scale. When we're talking about section GG, that's just the IRF-PI language. You don't need to know about that. But section GG is all this self-care and mobility stuff. And I just want to remind you again, it's not the intent by Medicare that when they introduce this stuff to have their baseline performance influenced by the therapeutic, rehabilitative, or compensatory strategies that we give them as part of our intervention. So again, baseline data prior to intervention. Some items might be kind of owned by a specific discipline, like our PTs here do car transfers. Our PTs do stairs. Our nurses do bowel and bladder. A lot of that is going to be totally different now. This is going to be a big mind shift for us, okay? There's going to be a lot of overlap. So if you're a PT and you're thinking, I don't care about ADLs, well, now we're going to. This is the scale itself, and it's different from the FIMS. So we're going to start, the scale is basically from 1 to 6. If the activity was completed, period, you were going to score them 1 to 6. If the activity was not completed, you're going to use what's called a special, and those are those codes at the bottom, those 4 codes, a 7, a 9, a 10, or an 88. And we're going to go through all of those. So you have a decision tree here, and a 6 means independent. So does the patient complete the activity with or without an assistive device? Does not matter anymore. By their self, no help, no cueing, no setup. If so, they are a 6, independent. If that doesn't sound like it fits, then you're going to go to the next one, which is a 5, called setup or cleanup assistance. In this category, the patient needs only setup or cleanup assist. So the helper either helps before or after, but not during the task. Okay, that's new. We never really had that in FIM language. So a 5 is setup only. A 4 is supervision, steadying, or touching assistance. So if the patient needs either verbal or nonverbal cues, or steadying, touching, contact guard assist from one person, if you're just very lightly helping them, then they're a 4. We never really had that either in FIM language. So a contact guard assist is a 4 in QIMS. The next category is a partial assistance. Does the patient need help? Like, do you have to do a little lifting or support their trunk? But the helper is doing less than half. The helper is doing less than half. So if you invert that, the patient has to do more than half of the work to be a 3, a partial assistance. The next category is a 2, a substantial assistance. So you ask yourself, does the patient need physical assistance like lifting, trunk support? And the helper does more than half. The helper does more than half, then it is a substantial assistance, which is a 2. For a 1, anybody that's been around for a while, this is familiar. Anytime you need 2 people, it's still going to be a dependent. That hasn't changed. Even if the second helper really isn't doing anything, even if it's a wheelchair follow, even if they're standing by just in case, it would be a 1 dependent. Okay, and then the other circumstance of dependent would be that the helper is doing everything. The patient's really not doing anything for themselves. So reminders for assessment of these GG items, you're going to assess the patient's self-care status based on observing them. So you're going to watch what they do, and we're going to score what they do. We're not going to guess what they could do. If you didn't see it, I don't want you to score it. Patients should be allowed to perform the activities as independently as possible. So we've always talked about fimmable moments. Let the patient be independent. Same thing, okay? This is our rehab culture. We want patients to do for themselves. We do not do them a service by over-helping them. So I want you to think QIMable moments. If it was not a QIMable moment, do not score it. If you put them in a wheelchair and you take them down to the dining room and you push them just out of convenience, out of time, whatever, do not score it. Okay, so again, if we're doing something to them, it's a time constraint, it's a convenience issue, do not score it. QIMable moments. And we want to provide those QIMable moments. So we're going to kind of go through the decision tree and the coding again. A 6 is independent if the patient did it by themselves with no assistance. We do not care about time anymore. You can do things really slow and still be independent. You can do things with a walker and be independent. You can do things all kinds of ways and be independent. So the independent category is a little more open than it used to be with FIMS. For a 5, setup, the patient only needs setup or cleanup. You're not touching them. You can give it to them and leave. A supervision also is steadying, touching, or cueing. So if the patient needs verbal cues, touching, steadying, contact guard, or assist, they're a 4. If the patient needs some physical help, like lifting or supporting, but the helper provides less than half of the effort, or the patient provides more than half the effort, then they would be a partial, a number 3. If the patient is doing less than half, then they are a 2, substantial. And if there's 2 people, or the helper is doing all of the work, then they're a 1. Pretty simple, right? Make it a little bit more complicated by adding in these 4 special codes. Okay, so the special codes are to be used if you don't see or the patient just didn't do the activity. The first code is 7, and that means that the patient refused. So that's pretty straightforward. So an example of a question you might get on your competency test is the OT asked Marvin to put on his shoes. He was having a moment. He wouldn't do it. She encouraged him. He just said, absolutely not doing it. Then you would score 7. Patient refused. The next special code is a 9, and that means not applicable. So if the patient did not ever do this activity, if they did not perform this activity prior to whatever they're here for, we wouldn't think that that'd be part of our plan of care. If they never did it, we're not going to get them to do it. And so this is a circumstance of not applicable. A 10 is not attempted due to environmental limitations. So if you lack the equipment or you have a weather issue, then that would be a 10. I'll tell you that that's really rare, and usually when you're going to see this on your test is like, it's a hailstorm, so we couldn't do a car transfer. Well, that would be a weather-related environmental reason, a code 10. The other thing that you might see, there's some kind of question about like, well, we couldn't do the steps because the rail was broken and so it wasn't safe. Well, we didn't have the proper equipment, so that would be a 10. On 88, we use all the time. Okay, so 88 is going to be really common, and I would say when in doubt, go 88. Not attempted due to a medical condition or a safety issue. So people get really confused between the 88 and the 9. I've sat through this QIMS test like 40 times now, and that's what people are getting most confused about. What's the difference between a 9 and an 88? Again, the 9, if the patient never did the activity, they're never gonna do the activity, it would be a 9. And then 88 just means they can't do it right now because it's not safe today. but they did do it last week or, before whatever happened to them. So an example of a 9 would be that Amanda had a spinal cord injury 3 years ago, and she's been a Hoyer transfer ever since. She has not sat on the edge of the bed for 3 years. Then we would code that score, sitting edge of bed, as a 9. She didn't do it before. She's not going to do it now. Okay? An example of an 88 would be that Amanda had a spinal cord injury 3 days ago. She's here for this new spinal cord injury. She's got terrible trunk control. Well, she used to do it. She just can't do it right now because she's not safe. So that would be an 88. Okay, hopefully everybody's still with me. Now we're going to dive into the actual domains, really what we're actually scoring. So as I said, for you as therapists, you will probably have an advantage because you probably already know what we care about in QIMS land. So we're talking about eating, oral hygiene, toileting hygiene, showering, upper body dressing, lower body dressing, putting on or taking off footwear. So we're going to start with that kind of set, and then we'll go through the rest. So when we're talking about eating, we're talking about the ability to use suitable utensils to bring food and or liquid to the mouth and swallow once the meal is presented on the table. So up until this point, you have not heard me say the term burden of care. Burden of care is a FIMS thing. So as of October 1st, we can totally forget about that. So always with FIMS, tube feeds were a 1. Like if it took burden, the nurse had to feed them, so they were a 1. This is different, okay? And this is also an area that's been tricky for people on the test. So definitely pay attention to this one. Tube feeds that are new are going to be an 88. Okay, it's not safe for them to eat because they have dysphagia. It's a medical reason we're not doing it. It's not safe. So they're an 88. If the patient has always had tube feeds, they've been on them for a year, 6 months, 2 years, 20 years, then we would not expect to fix that issue. We're not going to address that as part of our plan of care. And they would be a 9 because that's just completely not applicable to anything that we're doing. Okay, we only care about what they're eating and drinking by mouth. If the patient is a little bit of each, they have some tube feeds and they have some oral intake, we only care about the oral intake. We're going to completely ignore the tube feeds. That's captured somewhere else and you guys don't need to worry about it. Okay, so we're only talking about what we're eating by mouth. Don't let these questions mix you up. The next question is oral hygiene, the ability to use suitable items to clean your teeth. We can talk about dentures, taking out and putting in their dentures, soaking them, managing all of that good stuff. It also can include swabbing the mouth. Like if a patient has a trach and is MPO, we still want to clean their mouth, so you can count that too. For toileting hygiene, this should sound familiar because this is the same as FIMS. It's the ability to adjust their clothes, wipe themselves, and adjust their clothes. Clothes, wipe, clothes. That's all we care about toileting hygiene. If they were to have an ostomy, that would include wiping the opening, but not necessarily changing out the whole thing. So special circumstances like that we don't come across too often, we're just going to work through that as we really dive into QIMS land after October. The next category is showering, which is bathing, which similar to FIMS is washing, rinsing, and drying. Washing, rinsing, and drying are included in showering. Just like in FIMS, we're totally excluding the back and hair. So those are freebies. If they just need their back and their hair washed, we don't care. You could be sitting at the side of the sink. You could be doing it in bed, a tub, a shower, doesn't matter. Whatever you're doing bathing. But it does not include the transfer, and that's screwing some people up on their test, okay? So if it says they need 2 people to sit on the shower bench, and then once they're there, they shower themselves, and then they need 2 people to get back out of the shower. We don't care about that transfer, that shower transfer. That's not going to be a thing anymore that we have to report. So they would be independent in that category. Upper body dressing includes dressing and undressing above the waist, including buttoners and fasteners, and does not include a hospital gown. So that's the same as FIMS too, right? We can't just score a hospital gown. It has to be Walmart appropriate. It's a pretty low bar. but we want them to be appropriate. So upper body dressing now does include anything that's above the waist that they have to put on. So all these accessories, if you will. If they have a TLSO brace, if they have an Aspen collar, if they have an upper extremity prosthesis, we're going to include that in upper body dressing. We don't have to remember that just putting on a TLSO would make them a 5. That's weird. So they're simplifying it, and I'm glad. The next category is lower body dressing, which is the ability to dress and undress below the waist, also including fasteners, but does not include footwear because that's a separate category. It does include any braces or any lower extremity accessories, if you will, hip spica braces, knee braces, all that stuff, and even the whole leg, the prosthetic, a lower extremity prosthetic would be included in lower body dressing. But again, no weird rules to remember. You just think about everything that goes below their waist. Did they do more than half of the work or did they do less than half of the work? The next category is putting on or taking off footwear, which is the ability to put on and take off socks and shoes or other footwear that is appropriate for safe mobility. It does include TED hose. It does include AFOs. It would include if you, for some reason, only were wrapping like their feet. Anything that's below the ankle counts in putting on and taking off footwear. Also, if they don't have shoes or if they're too swollen to get in them, we can also include non-skid footies. So that's what they mean by appropriate for safe mobility. Footies do count now. Reminders when we're talking about 6s that use of a device or time completely we do not care about anymore. Okay, so they can totally be independent, even if they do it really slow or if they use the hip kit, the whole hip kit, that's fine. They can be the best of the best. The patient can use no device, take a long time to perform something, or be independent for the activity with adaptive equipment and still be a 6. Okay, so that's different from the FIM. Reminders for a 5. This only includes helper setting up or cleaning up. The helper assists before or after, not during. And this differs from the FIM in that a 5 in the quality indicators only pertains to setup. If they would require supervision or cues, then they're going to be a 4. So they are separating those out now. Reminders for coding a 4, which is supervision or steadying or touching assistance. This differs from the FIM in that a 4 in quality indicators is basically contact guard assist. In FIM land, a contact guard assist is a min, but now it has its own category. For a 3, the helper might have to lift, hold, or support the trunk or limbs, but the helper is doing less than half. Okay, so this is kind of like a FIM min and a FIM mod just squished together. We are not going to differentiate between mins and mods anymore. Now we're going to talk about some specific coding scenarios, and I think that these examples are super important because it helps us kind of talk out our rationalization, but also it's going to be really, really similar to what you're going to see on your tests. So I think it would be unfair to just throw you into a test if you have no idea what to expect. So all of these scenarios, you can rest assured that they're going to feel really familiar to you. And you might even have the same exact question. So we're going to start with eating, and remember that eating is by mouth only. So any assistance with tube feeds or parenteral nutrition is not considered. Okay? If a patient has new tube feeds, they had a stroke 5 days ago, they're here, this is new, then we wouldn't test them by mouth, and it'd be an 88 because we didn't do it because of a medical condition. If the patient never did it before, then it'd be a 9, not applicable because it wouldn't even be part of our plan of care. Okay? So we'll go into a question. Mrs. S has multiple sclerosis affecting her endurance and strength. She prefers to feed herself. After eating 3/4 of her meal by herself, she gets really tired and the CNA feeds her the rest. How would you code this? So here it says that she ate 3/4 of her meal, and so if we're thinking that is 75%, she of course did more than half. So she would be a partial assistance because she did more than half. The CNA did less than half. Now we're talking about oral hygiene. If the patient doesn't have teeth or dentures, you still can totally score it. if it's just cleaning the gums, okay? Mr. W does not have any teeth and his dentures don't fit. He begins to brush his upper gums after the helper applies toothpaste on his toothbrush. He brushes his upper gums, but he does not finish those upper gums due to fatigue. The helper completes the activity by brushing the back of his upper gums and all of his lower gums. How would you code this? The answer would be that he needed substantial assistance. So the helper did a little bit for himself, but he had to do all the bottom and part of the top too. So the helper is doing more than half of the effort. For toileting hygiene, it's the ability to adjust your clothes, wipe your butt, and adjust your clothes again. Mrs. Q has a progressive neurological disease that affects her fine and gross motor coordination, balance, and activity tolerance. She wears a hospital gown and underwear during the day. Mrs. Q uses the bedside commode. She steadies herself with one hand and tries to pull down her underwear with the other hand, but she needs assistance due to her coordination impairment. When she has a bowel movement, the CNA performs the perineal hygiene. She's too fatigued at this point, and she requires full assistance for someone else to pull up her underwear. How would you code this? So toiling hygiene in this circumstance would be coded as a substantial because the helper provided more than half the effort to complete it. She required assistance finishing pulling her pants down, wiping her booty, and pulling her pants up. So the patient themselves just did a little bit, so they need substantial assistance. Now we're going on to bathing. Again, already said earlier, but it could be a shower, a bath, sitting in the sink, in their bed. It doesn't matter really the location. Mrs. E has a severe progressive neurological condition affecting her endurance and gross motor and fine motor skills. She is transferred to the shower bench with partial assistance. When showering, she uses a wash mitt. Mrs. E showers while sitting on a tub bench and washes her arms and chest. The CNA must wash her with the remaining parts of her body due to her fatigue. She uses a long-handled sponge to rinse herself, but tires halfway through, and then the CNA dries her. How would you code this? So reading through this again, remember that we do not care at all about the transfer, okay? So they're going to throw a lot of extra junk into these questions to try to mess you up. They're going to throw a lot of FIM stuff, and then they're just going to throw a lot of extraneous. So you really want to weed down, what do we care about? Starting with she's transferred to the shower bench, we don't care about that. When showering, she uses a wash mitt. Do we care about that? No, we don't care about assistive devices anymore. While she showers, she's sitting on a tub bench. Do we care about that? No, we don't care about assistive devices anymore. She washes her own arms and chest, but then the CNA washes the rest of her. She rinses a little bit of herself, but needs the CNA to do a lot of that, and the CNA completely dries her. So it sounds like she's doing less than half of the work herself, so she's a substantial. Upper body dressing is putting on or removing shirt or pajama top, includes buttoning, includes all of the orthotics, prosthetics, anything listed here in blue, bras, undershirts, t-shirts. In addition to those kind of more obvious things, also TLSOs, abdominal braces, back braces, upper extremity stump socks, upper body supports, neck supports, or any kind of upper body P&O. Mrs. Y has right-sided upper extremity weakness as a result of the stroke and has worked in therapy to relearn how to dress her upper body. During the day, she only requires the CNA to put her clothes by her on the bed. Mrs. Y uses her compensatory strategies to put on her bra and top without any help. At night, she takes her bra off and she puts the clothes on the nightstand, and the CNA puts them away for her. How would you code this? So this would be a setup or cleanup only because all the CNA is doing is giving her clothes and then putting them back in the dresser. So she doesn't need verbal cues. She doesn't need to be steadied. All she's doing is helping before or after. So that's a 5. Just a reminder, no hospital gowns for upper body dressing. We've got some clothing reserves in the OT gym to assess upper and lower body dressing if the families haven't brought their clothes yet, so we'd prefer you to use that. But we do need a score. Lower body dressing. We're talking about everything except for putting on or taking off your socks and shoes, because remember, we separate that out. So the things we do care about with lower body dressing are underwear, depends, pants, socks, pajama pants, sorry, not socks, pants or shorts, capri pants, pajama bottoms, skirts, knee braces, bandages worn above the ankle, and then again, the prosthetic leg itself. Mr. B was admitted to a rehab following a total hip replacement. During his acute stay, he was unable to use the adaptive equipment due to severe arthritis. Mr. B cannot independently thread his pants or underwear onto his feet due to his hip precautions. Once the helper threads his pants and underwear, he pulls them up to his knees. He stands up, he pulls them around his hips, and he adjusts himself. The helper zips them up too. The helper puts on his socks and shoes. How would you code this? So this would be a partial because he required assistance of the helper to complete several steps. It's definitely more than contact guard. But remember that we don't care about socks and shoes. So they were trying to mess you up with that one, okay? So he's doing the stringing and he's doing the zipping. So that's a partial. The last one with the self-care category is putting on and taking off footwear. So we care about socks, shoes, AFOs, bandages on the feet, any foot orthotic, orthopedic walking shoes, compression stockings. We do include TED hose and AFOs, so we don't have to worry about all that goofy stuff like a TED hose is a 5 for FIM. We can forget about that come October 1st. Now we're just going to lump it all together, simplify it, and it does include retrieval too. Mr. M is undergoing rehab for right side upper and lower body weakness following a stroke. He's made significant progress, will be discharged home tomorrow. He wears an AFO, and he puts on his sock, and then he puts on his AFO, and then he puts on his shoes. He always puts his AFO, socks, and shoes within easy reach of his bed. While sitting on the bed, he needs to bend over to take on and off his AFO, socks, and shoes, and he occasionally loses his sitting balance, requiring touching or steadying assistance. How would you code this? So get a good picture of what he's doing and what he needs help with. And what you're really doing is just steadying him, making sure he doesn't topple on over to his noggin. So you're providing steadying assistance, so that's going to be a 4. We're going to consider the AFO as part of his clothes. For amputee patients that do not use lower extremity prosthetics, they don't have feet, they can't put on footwear, so it would be 9, not applicable. The next section we're going into is mobility. So we're changing gears a little bit. And I also want to take this time to remind you that, again, everybody's going to be scoring what they see. So all that self-care stuff we just talked about, if you were a PT and not paying attention because you didn't think you needed to know it, you need to go back and watch it again, because there's going to be a lot of times when PT will score toileting or PT will score putting on their shoes to go to therapy. So everybody is responsible for everything. So all the other disciplines should also be listening to this part about the mobility. I know OTs have never scored that here before. We don't FIM it, but now OT will totally be FIMing it. So, just another reminder that for a 6, that assistive device and time we don't care about anymore. Okay, so we're going to see a lot more of the highest level performers now than we ever did with FIMs. When we're talking about the mobility items, we're talking about rolling left and right. Going from sitting to lying, from lying to sitting on the edge of the bed, sit to stand, a chair or bed to chair transfer, a toilet transfer, and we're going to start there. So the first item is rolling left and right, and this is the ability to roll from lying on your back to your left and to your right side, and then return to your back. Okay, so like you're on your back, you roll to the left, then you get back on your back again, then you roll to the right, and then you come back to your back again. Doesn't matter if you start with the left or right, of course. if they cannot do it for a medical reason, you always have to ask yourself, did I see the whole task? And if you only saw them roll to the right, then you didn't see the whole task, so you can't score that. So you need to see the whole task to score it from that 1 to 6 scoring scale. If you didn't see them roll to the right, you need to look at those 4 special codes and you need to determine why. And so in most cases, if you didn't see them go the whole way, it's probably for a medical reason, right? So they probably have hip precautions, or maybe they have an open wound. And so the doctor wouldn't even let you roll all the way to the right. In this case, you would use the special code 88, not attempted because of a medical reason or a safety reason. All of the bed mobility items should be assessed on a bed, so you're not supposed to be scoring this from a mat or from like a jerry chair, laying down in a chair. They really should be on a bed, okay? So in that, I'm talking about those rolling items, sit to lying, and lying to sitting. They're pretty specific about that. But you can use your clinical judgment to determine what is considered lying for that patient. So there are a lot of patients that cannot tolerate lying completely flat. Our COPD patients, our tube feeders with aspiration precautions. We don't want them flat. So you as a clinician can decide what is, quote, flat enough, end quote, but you want to get it pretty much as flat as they can to simulate the home environment. Now we're going to go into a question. The PT helps Mr. R turn onto his right by instructing him to bend his left leg and roll to his right. He then instructs him how to position his limbs to return to lying on his back, and then repeat a similar process for rolling on the left. He completes the activity without any physical assistance. How would you code this? So the patient does need verbal cues, so he can't be a 6 and he can't be a 5. You don't need to put your hands on him, so he's not a 3, so he's somewhere in there. And he's a 4, supervision only. Mr. R has a history of skin breakdown. The nurse instructs him to turn onto his right side, providing step-by-step instructions to use the bed rail, bend his left knee, and roll on his right. The patient attempts to do that, but he can't do it, so the nurse has to roll him over on his right. Next, the patient rolls on his back all by himself. Mr. R then requires the nurse to roll him onto his left side. Okay, so now we're thinking about this, and think about how many steps are in that task and how many he did himself. So this dude needed help rolling to the right and rolling to the left. All he did on his own was roll on his back. So he did less than half of the work himself. The helper did more than half the work, so he's a 2, a substantial assist. Sit to lying is the ability to move from sitting on the side of the bed to lying flat in bed. Mrs. H requires assistance from 2 CNAs to transfer from sitting at the edge of the bed to lying flat on the bed due to paralysis, obesity, and her cognition. One of the CNAs explains to Mrs. H each step. Mrs. H is then fully assisted to get from sitting to a lying position on the bed. She does not make any attempts to perform any of that. What do you think? So in this question, we actually could have just stopped reading after Mrs. H requires assistance from 2 CNAs, because anytime there's a second person involved, they're always going to be a 1 dependent. That should be familiar to us because that's no different than the FIM. The next question is lying to sitting on the side of the bed, which is the ability to safely move from lying on the back to sitting on the side of the bed with their feet on the floor. Mr. B pushes up on the bed to attempt to get himself from a lying to a seated position, as OT provides much of the lifting assistance necessary for him to be able to sit. They provide assistance as he scoots himself up to the edge of the bed and puts his feet on the floor. Overall, the OT performs more than half of the effort. What do you think? The key here is that last sentence, and oftentimes on the test and stuff, that is going to be the case. Like if you read the last sentence, that's going to lead you where you need to go in at least 50% of the questions. The OT performs more than half, which means that the patient did less than half, so he's a 2, substantial assistance. Mrs. P is being treated for sepsis and has multiple infected wounds on her legs. Full assistance from the CNA is needed to move her from lying to sitting because she's got a lot of pain. That word full is code word for something. What is it? Full assistance means complete assistance, total assistance, dependent assistance, and they would be a 1. Sit to stand is the ability to come to a standing position from sitting in a chair, wheelchair, or at the side of the bed. Mr. M has arthritis and is recovering from sepsis. He transitions from sitting to standing with steadying or touching assistance of the nurse's hand on their trunk. How would you code this? Why? So if you paint the picture in your head, all they're doing is kind of holding on to the gate belt, just making sure they're steady, and that is always going to be a 4. Steadying assist. Now we're talking about transfers. A chair to a chair or a bed to a chair transfer is the ability to transfer to and from a bed to a chair or a wheelchair. I really like about the quality indicators, even though it seems kind of tedious, I would say rolling side to side, sit to lying, lying to sitting. I feel like it sets us up better for more accurate data, because really in the BIM land, to score a transfer, you really are supposed to see them go start and end in supine. And how often does that happen? That's just not realistic for us. So now they chunk it out, and you just can score what you see. So I really like that. Okay, with the transfer, if they use a mechanical lift or 2 helpers, they're going to be dependent. Here's a scenario. Mr. F's medical condition includes morbid obesity, diabetes, and sepsis, and he recently underwent bilateral above-the-knee amputations. He requires full assistance with transfers using a lift. 2 CNAs are required. He's unable to assist. How would you code this? Hopefully everyone got this one right, because that's a super low-hanging fruit. It gave us lots of really good cues. Going back up to the second point, he requires full assistance. That's their first clue to you. Full assistance, total assistance, dependent assistance. He also uses a lift device. When you see a device, they're going to be a total. Then the next thing says he needs 2 CNAs. So that's your third clue that they're looking for a dependent score. And then the fourth clue is where it says he's unable to assist at all. So this is a dependent one on number 1. Mrs. P has metastatic bone cancer affecting her ability to use her lower and upper extremities during daily activities. She's motivated to assist. She pushes herself up from the bed to begin the transfer while the therapist provides trunk support. Once standing, she shuffles her feet, turns, and slowly sits down with the therapist providing trunk support. Gosh, I think that just described like 90% of our patients, right? Overall, the therapist is providing less than half of the effort. How would you code this? Okay, so you always want to ask yourself, is the patient doing more than half or less than half? And in this case, the therapist is doing less than half, so the patient is doing more than half, so they are a 3, a partial assist. Patient had a stroke and has left hemiparesis. When rolling, the patient requires assistance of 1 helper with both the upper and lower extremity on the paretic side. The helper does less than 50%. I'm just going to stop right there and let us think about that. So what would they need for rolling if the helper provides less than 50%? He requires the assistance of 2 people to come to a sitting position. So what do we think for lying to sitting? And the 2 people to go sit to transfer to the wheelchair. Sorry, to transfer to the wheelchair. So think about what you want to answer for transferring to a wheelchair. He is unable to safely stand. So based on that, what would you say for sit to stand? When he gets back in bed, he requires 2 people. What would you say for that? Okay, so this is a multi-part here. For rolling left to right, he'd be a partial because he required assistance of 1 person with both his upper and lower extremity, but he is doing more than half of the work. For sit to lying, he requires assistance with the upper and lower extremity to return to lying. For lying to sitting, he required 2 people, so he's a 1. That's your easy one. Sit to stand, he never did. They got him side of the bed, and then they did a Hoyer lift. So we didn't see it. We can't score it. You got to go to your special codes and figure out which one makes the most sense. He didn't stand because it's not safe for him to stand, so he's an 88. And then for the actual transfer, he required 2 people, so he'd be a 1. The next item is toilet transfers, which is the ability to get on and off a toilet or a commode. We don't care about assistive devices anymore, so even if we're in the bathroom here on TRC and they've got the grab bar or they have a toilet riser, we don't care about any of that. We're just thinking, did the patient do more than half or less than half? Make sure that you're not getting confused about toilet hygiene, which is close, wipe, close, and then the transfer, okay? They're 2 separate things. They kind of try to trick you with that. And then also bedpans are not included, so we wouldn't score someone as a 1 for getting on and off a bedpan. Mrs. Y is really anxious about using the bathroom. She asks the CNA to stay with her as she gets on and off the toilet. The CNA stays with her and provides instructions to her. How would you code her? Why? Okay, so she needed instructions, and instructions is a code word for queuing, and so that would be a 4, cues or studying assistance only. She didn't have to put her hands on her, so that's great. Mr. H has paraplegia, pneumonia, and COPD. He prefers to use a bedside commode when moving his bowels due to his weakness, history of falls, and dependent transfer status. 2 CNAs assist him to the toilet. That's the easy one. What do you think? Of course, that's a 1. Anytime you see 2 people, that's going to be a 1. The next one is car transfers. And I think just pay attention to this one because some clarifications here. And I think some of these are pretty recent clarifications from CMS as well. So when we're talking about car transfers, we're talking about the ability to transfer in and out of a car or van on the passenger side. In and out, not in or out, okay? Does not include opening or closing the door or fastening a seatbelt. So it's just the physical part of like actually getting in. I say that about the in and out because that's really going to be you guys. It's not going to be like the CNAs put them in the car to go to a medical appointment because they are only putting them in, so they can't score that because they didn't see in and out. And CMS also provided a clarification that like if the same CNA puts them in the car and then 6 hours later gets them out of the car, they still shouldn't score that. So it should be like within one setting that they're getting in and out. Totally fine to use the car simulator like we have. Does not include transfers into the driver's seat, as well as what I already said. Don't care about closing or opening the doors. Don't care about doing the seatbelt. If you can't do it because of inclement weather, because they like a facility doesn't have a car simulator, then you would say not attempted due to environmental limitations, which is code 10, which is pretty rare. And definitely we don't have that problem here because we have our car simulator, which we're really fortunate to have. If the patient just isn't safe to see or to try it, then we're going to see an 88. And I see a whole lot of 88s on this, and that's totally fine. If a patient is way too unsafe to even practice this, just 88 them. During her rehab stay, Mrs. N works with an OT on transfers in and out of the passenger side of the car. On the day before her discharge, she requires verbal reminders for safety and light touching assistance as she transfers into and out of the car. The therapist instructs her on her hand placement as she transitions to sitting on the passenger seat. She needs light touching as she moves her feet into the car once seated. The same amount of assistance is needed for her to transfer from the car seated to a standing position, and the therapist manages the door. Give you a moment to think about that. So the answer would be that she needs verbal cues and steadying, right? Contact guard assist and verbal cues, so she would be a 4. How are we doing? Everybody still with me? Awesome. Now we're going to go into mobility items. So this is all the walking stuff. And as I said before the last section, this is not PT's sole responsibility any longer. So a lot of us are going to be scoring a lot of these things, OT. A lot of CNAs are going to be scoring a lot of these things, okay? So the first thing we're talking about is walking 10 feet. We're also talking about walking 50 feet with two 90-degree turns, and then also walking 150 feet. We also want to see them walk 10 feet on an uneven or sloping surface, like turf or gravel. When we're assessing the patient for these walking items, do not consider the parallel bars. Parallel bars are not portable. Okay, this is a favorite question on the test. If we're talking about parallel bars, they're not really walking because you can't walk with the parallel bars. So if the patient cannot walk without using the parallel bars because they wouldn't be safe to, then you would code 88, activity not attempted because of a safety reason. I attempted to get some clarification from CMS about a handrail, because that too is not really portable, but it seems like they say that you can go ahead and score with the rail. Okay, so we're really just talking about parallel bars as being, quote, out of bounds. Another kind of clarification is that a patient may take a brief standing break, like a little breather, when they're walking 150 feet, and clinicians can use their own clinical judgment to determine whether it's just, basically a breather. So with the FIMS, all the time, FIMS, they have to get to 150 feet. Oh my goodness, I have absolutely seen people document that a patient walked 148 feet, 149 feet. The nice thing about this is that it's telling us they can just take a little standing breather for a minute and then continue on, okay? So if they're getting really close and you think like they really can make it without sitting down, let's kind of try to push for that, okay? If it's safe. The turns, when we're talking about 50 feet with two turns, they have to be 90-degree turns. They can be in the same direction, different directions. We don't care which directions they are, so long as there are two of them. The 90-degree turn should occur at the person's ability level and it can include using a cane without affecting coding. So that's no different than everything we've been talking about today. Seems like in the examples I'm reading, they're talking a lot about turns as like they came out of the room and walked down the hallway. That's a turn. Or they had to go to the bathroom. They had to turn to get in the bathroom. So you can kind of like fill in that hole. You would know that they need to turn. Let's try a scenario. Patient is able to ambulate 50 feet with two turns using her walker. She is unable to maneuver her walker on uneven surfaces, so PT provides steadying assistance with one arm holding her gait belt, the other arm actually moving the walker forward for her while she walks 10 feet in the grass. She is only able to walk 100 feet. She can't get to 150 feet because she's very short of breath. So how would you code walking 10 feet? Let's kind of go back, okay? So first she walks 50 feet, makes the two turns, uses her walker. So they're not saying it explicitly, but they're pulling the 10 feet one out of that. She does it. It doesn't say she needs help, so we're going to give her a 6 for the walking 10 feet. We're also going to give her a 6 because she's able to ambulate 50 feet with two turns using her walker. So she's going to be independent for that too. So we're going to give her a 6 for that. Was she able to walk 150 feet? No, she was not. She only walked 100 feet because of shortness of breath. So it sounds like it would be unsafe for her to do that. So we're going to 88 that. And then walking 10 feet on uneven surfaces, that's a little bit more challenging on this one. So it says they're steadying her with her belt, and then the therapist is moving the walker forward. Okay, so we would definitely say that's more than steadying assist, right? We're doing more than just contact guard. So again, walking 10 feet, she was independent. Walking 50 feet, she was independent. She could not make 150 feet because of a safety concern. And then she needs partial assistance for walking 10 feet because she needed more than steadying assist. And then that side note at the bottom is just showing you that for a FIM score, it should be a 2, but the FIM and the QIM, they don't 100% directly correlate. The next categories are steps and picking up objects. So we're going to talk about one step or a curb. If you get a question and it just says like there's no curb available, but they did one step, that's fine. It says it right there in parentheses. They're doing one step and or curb. 4 steps, with or without a rail. We don't care about assisted devices anymore. 12 steps, or picking up an object from the floor. 4 steps. Mr. J has lower body weakness, and the PT provides touching assistance while he goes up 4 steps. When he comes down those 4 steps, the PT is providing trunk support, which is more than touching assistance, and he holds on the stair rail. We don't care about the rail, that's extraneous, right? But he did require more than touching assistance, so that makes him a 3, a partial assistance. Picking up an object is the ability to bend or stoop from standing to pick up a small object like a spoon from the floor. So some ways it might trip you up if it says like he's doing it from a wheelchair. We didn't see it because it's got to be standing. Also, it doesn't need to be a contrived situation. Like, I think that's how we're doing it now. We throw something on the floor and tell them to pick it up. But if we just see this, like just, they're doing their ADL and they drop their toothpaste and they bend over and they pick it up while they're standing, you can score that. So a real functional task. If they're in the shower and they're standing to shower and they drop their soap and they bend over and they pick it up, you can score that. Mr. P has a neurological condition that has resulted in coordination problems. He wants to be independent. He lives with his wife and he's going to be going home soon. He tends to drop things. He probably doesn't like dropping it. He's been practicing bending or stooping from a standing position to pick up those small objects from the floor. OT needs to remind him of safety strategies when he bends to pick it up, and she needs to steady him. So she just got her hand on the belt, just kind of touching, in order to prevent him from falling. How would you code this? So go back through and pick out the code words. And the code words for this is she's giving him verbal safety strategies. So she's giving him verbal cues. She's also giving him contact guard assist to make sure he doesn't fall over. So those make him a 4, a steadying assist. Guys, we're getting there. Hang in there. This is a lot of content, but you're doing great, I'm sure. The next category is wheeling 50 feet with 2 turns. And the next category after that is wheeling 150 feet. So we're talking about manual or motorized. Doesn't matter. It can totally be electric. That's fine. We can still score that. We need to use our clinical judgment to determine whether they're using a wheelchair for mobilization or just because it's convenience. Okay? If the patient walks and is not learning how to use a wheelchair and only uses a wheelchair for transport between the locations, we're going to code the gateway items as a no, and we're going to skip the rest. So let's kind of go back through that. If basically you have a high functioning level patient, we're using the wheelchair sometimes just to like get him down to therapy, but he's not going to need it at home. He doesn't really even need it now. We're just doing it out of convenience. We wouldn't need to score wheelchair. My advice as a program director is to err on the side of caution. So if you're not sure if the patient's going to need it or not at discharge, you definitely want to see it on admission. Okay, so let's be conservative about that. That's what that says kind of in orange down there, because there's a lot of times where we think a patient will be totally independent at discharge, but we were wrong, and maybe they need a wheelchair for community mobility, for any kind of distance stuff. So in which case we need a baseline assessment as well. When we're talking about the turns, same as walking, 2 90-degree turns. 150 feet is the ability to wheel once you're already seated in the wheelchair, because we're going to capture the transfer and everything else in other categories. So when you're thinking about it, he already starts in the wheelchair, and then we're also going to be saying if it's manual or motorized. Once seated in a manual wheelchair, Mrs. R wheels 10 feet and then asks the therapist to push the wheelchair an additional 40 feet into her room and then into her bathroom. So this is kind of a tricky one, and a lot of these wheelchair ones are super goofy, okay? So the first thing I want you to ask yourself is, when all is said and done, did she do 50 feet and 2 turns? So what it's saying here is she did 10 feet. The therapist did the rest, the 40 feet for her. So in total, she did go 50 feet. And then she had to get into her room and her bathroom. So if you're like picturing someone coming in from the hallway, they'd have to make a turn to get in their room, right? And another turn to get in their bathroom. So yes, the answer is yes, that even though she couldn't do it, we wouldn't 88 her because the whole task was in fact done. So now the next question is, did she do more than half or less than half? She did 10 of 50, so she did less than half, so the answer is 2. I could see how someone would get really easily confused and think that this was an 88, like she just couldn't do it, it wasn't safe, she was had poor endurance, but it is looking for 2 here and on your test. If you're a therapy assistant, you can kind of tune out for a minute because I'm going to talk with the therapist for a minute. For discharge goals, I want to make sure that you guys know, all of our documentation is changing with the Expanse and the Meditech upgrade and everything, but want you to know that as of last year, you should be using the special codes, those activity not attempted, to report their goals. So if we're not setting a goal on someone because they are a bilateral amputee, they never walk, they're never gonna walk, instead of putting like dependent, which I see this a lot for sit to stand and walking and stairs. Instead of putting a 1 saying they're dependent, we really should be putting a 9. Like that's just not applicable. We would never do that. Okay, so we're going to work through a little bit more of that with your Expanse training. When you're setting goals, really, this is nothing new, but you want to think about their expected length of stay, their current abilities, their personal actual goals for themselves, what kind of family supports and stuff like that. And so you're basically co-establishing the goals with the patient. And this is super intuitive for us as therapists. I think everybody does a really great job. I've never seen any issues. But what you should not be doing is going in and being like, to a patient who has been completely incontinent for 10 years and going, hey, what's your bladder goal? Oh, you would rather be independent? You want to be independent? Okay, good goal. That obviously is not realistic. So just make sure your goals are realistic, okay? Can you establish a discharge goal for anything you answered 88 to? Yes, absolutely. Just because a patient couldn't walk 50 feet the first day doesn't mean we're not going to work towards that end. So you'd still want to set a goal for that. All right, so now everyone needs to pay attention again. Thanks for that brief break. Obviously, I'm not there, so you can't really ask me any questions, but this is a good time to tell you that my phone number is 618-604-7004. And if you do have a question right now, I don't care what time it is, you can call me and ask me. All right, we've gotten through the content. Whew, you guys made it. Proud of you. This is dense. Now we're going to talk about the test. So I'm not sure when you're watching this. Your leadership is still kind of trying to decide when our official deadline is. So whatever Sarah or Julie or Kim or Wendy told you is your deadline is your deadline. We're just trying to get all these tests passed absolutely as soon as possible. Everybody is going to have a code sheet that you would have gotten from your manager, and it looks like this. All the information that you need is absolutely on this. So when we did the FIM stuff, everyone kept calling me, I don't know what the website is. Well, the website is under step number 1. I don't know what my key code is. The key code is at the top where it says key code. Okay, so everything that you need, I promise you, is on this sheet. I do want to point out that sometimes this UDS system gets a little finicky. So if you're having problems and it's saying like session inactive or something like that, try to open up Chrome. It likes Chrome better. So go Chrome when in doubt. If you're still having troubles, give me a call and I'll see if I can walk you through it. The code is only valid one time. We expect all of our staff, there's about 100 of us, everyone needs to take this test until they pass it. We want to make sure it's super important. We've went through the reasons why. I want to make sure that you really have a good grasp of the concepts. Even if you only come to TRC once a quarter, you're coming for one day, you're really impacting that patient's day and that patient's life, as I was saying. So we want to make sure if your feet are ever in TRC's doors, I want you to feel good and confident that you're doing this correctly. If you do fail, no big deal. It happens. You'll need a new code, you'll need a new sheet, and you'll need to get that from me. So shoot me an email, give me a call, and I'll get you set up there. You can hit the later button if you need to split your test into 2 sessions. But if you hit later, that starts a time clock and you only have 5 days to finish it up or it will fail you. So you can't hit later and come back to it next week, or you can't hit later and come back to it in 2 weeks. You'll have already failed. This is open book. So please use your resources. I'm going to email out the PowerPoint, and then there's also help documents. I'm going to go through that in just a second. I want to make sure everyone's reading the questions completely, and make sure you pay really close attention to what domain you're talking about. Ignore the stuff we used to care about with FIMS and we don't care about anymore. Weed through anything that's not relevant. If it's talking about a shower, we're only caring about their washing, rinsing, and drying. We don't care about their hair. We don't care about their back. We don't care about the transfer. We don't care about the assistive devices. So really hone in on what it is they're asking. Don't hesitate to text me if you want to talk anything through. My number is 618-604-7004. You can screenshot me the questions. I want you to understand. At the end of the test, you can see how many you got right. It's just pass fail, okay? So you need 80%. So you have room. Don't sweat. Don't panic over one question. You can miss quite a few questions and still get a fine grade. And then at the end, it's going to tell you there's an option to review what you got wrong. I think you should review that and just think it through, because I want you to know for your knowledge. If you want to send me a text, picture, or a screenshot in my email of the question, I'll tell you what the right answer is, because I want you to know. I'm less concerned about you passing this test, and I'm way more concerned about you actually understanding this content. But when you do that review at the end, it doesn't tell you the right answer, and it also doesn't tell you what you answered. So not super helpful there. Every single test is different. So if you're an OT and you're sitting next to your OT friend, your tests are going to be completely different. Every test is a different number of questions depending on your discipline. The PT's test is different from the OT's test, is different from the nurse's test. This is where what your worksheet should look like. You can't you can't even take your test without one of these sheets. If you don't have this sheet, text or email or call your manager. This is what the website looks like. See where my arrow is pointing? Blue bar only. Don't put anything up in those: facility code, username, password. You're not looking at that. You're going straight where my arrow is. You put your key code in there. Just follow the instructions on your sheet. That pulls up this introduction sheet. You're just going to hit continue. You're going to fill out your information on this sheet here. Make sure you are using appropriate spellings, appropriate capitalizations. If, God forbid, you do fail, you need to know what you put last time, because otherwise the system thinks you're two different people. So if your name's Mary Ann, don't put Mary in your first name and Ann in your second name. And then the second time you take it, put Mary Ann on the first name line. We just have to be consistent, okay? Or if you're Jamie Beatty, use Jamie and not Jamie and Nikki. Just keep it separate for yourself. You can answer the questions using the drop down. I'm comfortable with you therapists saying that you've used the QI items for however long you really feel you've been using them. We haven't really been using the coding language, so I think it's appropriate for you to say that you've used it less than 6 months. The primary method of quality indicator training was in service, so you're watching this video. You can hit video too, but basically this was the same recording of it in service I gave in person. And then you want to hit continue. Top left, what I have circled here, that's how many questions you have. Like I said, everybody's test is different, but that's how you can kind of monitor where you are. I don't have it circled, but bottom left there is that later button. I said you can push it. Remember, you only have 5 days to finish it up. Make sure you use your drop down. It's going to give you the whole definition, so you don't have to remember 1, 2, 3, 4, 5, 6. You can remember 3 is a partial, because it's going to say that for you. Up in the top right are your help documents. Use the help documents. Might take a little bit extra time, take 5 minutes to look something up, but it's better to take extra 5 minutes and get it right than fail your test and have to take it for an hour and a half. And people are taking anywhere between 30 minutes and maybe 75 minutes from what I've observed for the test. So that's how much time you need to block out. But again, you can do it in 2 chunks if you need to. When you hit that help documents in the top right, this is the page that it pulls up, and this is all of the resources that are available to you. This is the straight IRF-PI manual, so this is the definitive coding. It's got a lot of examples and stuff, so feel free to use them. This is what one of the examples is, one of the resources. Physical therapist or a speech therapist are pretty much done. I guess speech therapists maybe stick around because we're trying to decide who's going to do these BIMs and stuff going forward. So OTs and CODAs need to stick around. So sorry, CODAs. We couldn't differentiate with your tests between the OTRs and the CODAs. So even though you've never had to do this and you've never been exposed to this, you will be tested on this. So this is why I want you to watch this little training. This little training that I'm about to do makes you in no way competent to do the BIMs. And we do have a upcoming BIMs seminar, like just a training session just for the BIMs, just for the OTRs. So we are going to hit this more in depth, but I want to give you some pointers because there are test questions about the BIMs and I don't want to set you up for failure there. So the cognitive FIMs that we all know and love are going away, and I could not be more excited about that. And they haven't really replaced it with anything very good yet, but what they are looking at is just expression and comprehension. 2 one and done items that you answer on admission. So the OTRs are assigned this. They do this on evaluation. You guys know what the BIMs are with a red, blue ball. But part of that also that they're answering is expression and comprehension. So we're going to start there. It's not really technically part of the BIMs, but it's just the cognitive part of the assessment. So when we're talking about expression, we're just saying in that first 3 days or at their baseline, how well the patient expresses their ideas and wants. And we need to consider verbal and nonverbal expression and exclude any language barriers. So we wouldn't say that a patient can't express themselves just because they only speak Spanish. So for the options, the actual definitions are there, and they'll be there in the drop downs on the test too. So out of 4, the patient expresses complex messages without difficulty, with speech that is clear and easy to understand. And then just a little clarification with that speech that is clear and easy. They can also answer in writing, and we would count that as a way to express themselves. At a 3, the patient would exhibit some mild difficulty. So they might have some word finding issues or difficulty finishing their thoughts, or their speech is just really not clear. But we're still talking about complex messages. At a 2, the patient frequently exhibits difficulty when expressing themselves. And at a 1, they either rarely express themselves or never express themselves, or speech is very difficult to understand. A lot of the questions have that exact same language. So if you see in your question it says, Amanda has a very difficult time understanding, then you can just look which one of those says very difficult. Oh, she's a 1. We're going to assess this using the patient's preferred language. You're going to obviously interact with the patient. You want to make sure that they can hear you. Also, if they have a hearing aid, you want to make sure that that's on. You want to set up the environment for their success. So turn off the TV, try to make everything quiet, and you want to observe them. We already kind of went through that. The takeaway for this slide is that complex messages are 3s and 4s. Complex, 3s and 4s. And you guys know about complex because we always talked about complex with our FIMs. We're talking about things like, do they understand their medicine, their discharge plans, stuff like that. Complex. If they can't do complex, we're automatically dropping them to a 2. So what I've seen is that we score a lot of 3s and 4s. Lots and lots of 3s and 4s. It's pretty rare to get anything under a 3 and 4. So we probably overscore these people a little bit. We probably make them look better, a little bit better than they do. So if you want to get your input from your teammate, the physical therapist, the speech therapist, the nurse, certainly that's totally kosher to get group feedback before you score that. Mr. B had a stroke several weeks ago. He has expressive aphasia. The CNA asks him if he needs help bathing. He looks at her and smiles but doesn't respond. The CNA reports to the nurse that she's not been able to determine his preferences and his needs. The nurse interacts with him. He rarely expresses himself. They plan to collaborate together with speech to try to address this. So the answer is going to be that he rarely or never expresses himself. He's very difficult to understand. As I said, the answer is just right there in the question. I'm going to go back 1, and it says the nurse interacts with him, determines he rarely expresses himself. That just gave you the answer. Rarely expresses himself. Likewise, there's a comprehension or understanding, and we're talking about verbal and nonverbal content. Could be with a hearing aid, excludes language barriers. At a 4, they understand without cues or repetitions. At a 3, they understand most things, but they might miss some parts of the message or require some cueing. At a 2, they understand only basic conversations, simple phrases. They frequently require cueing. And at a 1, they just rarely or never understand. Do the same thing as you did before. Interact with the patient, talk with your teammates. Basic, if we're talking about basic, we're automatically no higher than a 2. Complex stuff, 3s and 4s. Mr. K has been participating in PT to improve his bed mobility. The PT reports he occasionally requires repetition of instructions. The nurse also reports she had to repeat some information to reinforce what she was saying about his medications. What do you think? He usually understands. He requires some cues. He requires a little bit of, how did they express it? Reinforcing. So he usually understands a 3. As you've already noticed, I'm sure this scale is completely different than the 1 to 6 scale that we're using with the other QIMs. Now we're going to get into the BIMs. And again, this isn't meant to make you an expert on the BIMs or anything. This is not too great of a training, but it's just as quick as I can to get you to be able to pass it on your test. So the BIMS is the brief interview for mental status, and the intent is to determine the patient's attention and orientation and recall. This is one time and done. We completed at admission. So right now, the OTRs are completing the BIMs when they do their evaluation. And our expectation is that's going to be within 24 hours of admission. Once and done. So you don't do it today and then again at discharge. I do think probably in the future we will have to do it on discharge too. But that's not our problem right now. So right now, once and done. One of the questions. So when we get to the test, make sure that you're using the scroll up and down because a lot of people didn't see that it's like a 10-part question with the BIM. So make sure you're finishing the BIM specifically to completion. So the first question is going to be, should we do the BIMs? And the only reason that you would not is if in that expression and comprehension assessment that we just did, if they got 1s. Like they're bad. They can't express themselves. They can't understand anything. You wouldn't waste your time. They're going to get a terrible score on this. So that is the only situation in which we would say, nope, we're not doing the BIMs. So if they're double 1s, you would code a no, and then you would go on. But if a patient was a 1 and a 2, or anything higher than that, you would say, yep, we're trying it. We're doing the BIMs. If the patient needs an interpreter, we need an interpreter for the BIMs. If the interpreter can't be present or if the patient's deaf, it's very acceptable to do it like in writing. And if that's the case, let's talk about that one-on-one. So basically the first thing you're going to do is say, I'm going to ask you some questions. We ask everybody these same questions. This is going to help us provide you better care. Some of the questions are easy and some of the questions are hard. And if they're like, my memory, don't like that, kind of makes people a little uncomfortable sometimes, just go, we ask these for everybody because we have to. We want to complete this in one sitting, so make sure that you're not saying, giving them their 3 words in the morning and then your afternoon session, you can't be like, what were those 3 words I told you? It needs to be in one sitting. It should only take about 3 minutes to complete, so it's pretty fast. So the coding system on this is going to be available in your dropdown. Basically, they got it right or they got it wrong. And sometimes you're going to code a 0, and a 0 just basically means wrong. So you would code a 0 wrong if they answer the question wrong. It might be logical, it might make sense, but it might just be plain wrong. So if I ask Elizabeth what day of the week it is, and it's Monday, but she says Friday, that makes sense. It is a day of the week, but it's just wrong. So she'd get no credit. You would also say they just got it wrong if the patient answers something nonsensical. So I like to call that a wackadoodle response. So if I said, Elizabeth, what day of the week it is, and she said oatmeal, then that's a wackadoodle response, and we'd give her no credit. Or if I say, hey, Elizabeth, what day of the week it is, and she said, I'm not telling you, and she refuses to even give an answer, we're still going to count that as wrong. So even if it's like a behavioral thing. So the first thing you're going to say is I'm going to say 3 words for you to remember. Remember the words after I have said them. The words are sock, blue, and bed. Now tell me those 3 words back. And the first thing that you're going to score here is the number of words they got on that very first try. So if they say sock, I don't remember, then you're going to score them in 1. They only remembered 1 of those. I'll tell you, most of our patients actually remember all 3 of those. If they don't get it, you're going to repeat the words, but you're going to use cues this time. Okay, so let's say I say, Amanda, sock, blue, bed. Say those words back to me. And she says sock. I'm going to go, let me tell you them again. Sock, something to wear. Blue, a color. Bed, a piece of furniture. And she's going to try to say it back. You can say it up to 2 more times. So those are what we call category cues. If the patient does not repeat all 3 words after 3 attempts, you're kind of supposed to stop and reassess. Can they hear you? If you think that they can, go ahead and just keep moving on. But if it's just a hearing issue, we're going to alter their environment. Turn the TV off, go get them a hearing amplifier, set them up for success here. So you're recording the maximum number of words the patient repeated on the first attempt. We're not even scoring what they do on their second or third try. And now we're going to go into orientation questions. So you're going to ask these patients these questions separately. So the first orientation question is, tell me what year it is right now. The options are they either got it right, they missed by 1 year, they missed by 2 to 5 years, or they missed by more than 5 years. So pretty simple. You just assign it whatever they say. Or they don't answer. Or they said something nuts, then you give them a 0. They just got it wrong. What month are we in? If they got it right within 5 days, you give them full credit. They get kind of partial credit if they're within a month. And if they miss by more than a month, or they can't answer, or they say something that's crazy, then go with a 0, no credit. Then you're going to ask them what day of the week is today. And they either get it right or they get it wrong. So pretty simple there. Don't provide any clues. Don't say like, it's bingo day today. If they ask you for help, just be like, I just need to hear what you think. All right, this I'm only including, I know we really haven't been doing this so much in practice, but I'm including this for the test purposes. So after you get through that part, the BIMS is not quite done at this part, by the way, but at this point, after you've asked day of the week, you've asked them the recall, you've asked them the year, the month, and the day. If everything has not made any sense, then we'd stop the test. If they are just refusing to participate, then you'd stop the test. If there's been any combination of nonsensical and no response, like sometimes they just won't answer, sometimes it's nonsensical, then you'd stop the test. If you stop the test, then you would code a dash in the next 3 questions. There's 3 more questions of the BIMS. So basically you're coding a dash because we didn't give them the opportunity. We can't say they got it wrong because they probably would. That's why we're stopping it. But we didn't actually ask them, so we're going to code a dash. That's the only time you've ever heard dash in this presentation. And then if you don't complete the BIMS in its entirety, then we have to do something else. And I know this is new information for you guys. So if we can't get through the entire BIMS, then staff should complete what's called the staff assessment for mental status. Okay? We would not complete the staff assessment for mental status if you could do the BIMS. The BIMS is better. The staff assessment for mental status is kind of like in case of emergency. These are the last 3 questions of the BIM. So again, we asked the year, we asked the month, we asked the date, and now we're going to say, let's go back to an earlier question. What were those 3 words I asked you? If they can't remember it, hopefully they'll just say sock, blue, bed, and they'll get 2s in all these categories, which you can see means, yes, they remembered it without a cue. If they don't, you would say the cues. So you'd say something to wear, a color, and a piece of furniture. And then if they could get them after the cueing, then you give them a 1. And if they don't remember or they just won't answer you, then it's a 0. Okay, the BIMS gets a summary score, so you just add up the score. The scores could be from 0 to 15. We'd put a 99, just in case that comes up on your test. You'd put a 99 if you just couldn't do it. The patient can score a 0 on this test. We kind of already went through that. A 13 to 15 indicates cognitively intact people. An 8 to 12 is a moderate impairment, and a 0 to 7 on the BIMS is severe impairment. This is supposed to guide our clinical practice, making sure that we don't miss anyone that does have like more mild cognitive impairment, because basically some facilities are using this as like a hard and fast cutoff that if they get a 12 or below, they automatically have to see speech for at least a screen. We haven't done that yet, but you're really supposed to use this for your clinical practice. Back to that staff assessment for mental status. Again, this is only conducted if you weren't able to do the BIMS in its entirety. That's the only time you'd say yes to this. Otherwise, like on your test, if you've completed the whole BIMS and it says, what should you say for the staff assessment for mental status? You're going to select where it says, just skip this. Okay, it's kind of tricky. The content of this staff assessment for mental status, which I call the SAMs, no one else has, but is these things. You want to know if they know the current season, the location of the room, staff names and faces, and that she's in the hospital. And it'll be very obvious on the test because it'll say like, Sarah remembers that it's winter, but doesn't know anything else. And so you would say, yep, she knows the season, and then leave the rest of them blank. Okay? Okay, and we're working in our own EMR system. Right now, what would happen, like if someone get a double one and I know that they need this staff assessment for mental status, I either talk to the people that are taking care of them so we can figure out these 5 answers together if they know the season, the location, or more times than not, I just go and have a conversation with the patient during my rounds at bedside, and then I just ask them these questions, and then I document it myself. That's why you haven't ever done the staff assessment for mental status. Okay, I'm not going to just have to go over what the current season is. That's all really self-explanatory. There are a lot of BIMS resources. I would not even recommend doing that right now because we're going to plan this upcoming course. So it's all going to be good. For the testing, the BIMS questions are multi-part. So as you see it right here, that's kind of what comes up in your screen. And there were a lot of people that missed about 9 other questions that are hiding below that. So where my arrow is pointing to the down bar, make sure you're looking. And then what I have circled there, Wednesday, October 31st, 2018, make sure you're paying attention to that for all those orientation things. It's telling you a specific date. Don't just guess that it's like today's date. And you finished the exam. So good luck on your test. Thanks for your attention. And please, please, please reach out to me with any questions you have because this is definitely a work in progress. So thanks for your time.